Welcome to Qualified Opinions, where we test the ideas and limits, the knowns and known unknowns around freedom and order in contemporary politics and society. We invite you to listen as we engage with leading and emerging thinkers across disciplines and issues who will sharpen our thinking on the topics shaping our discourse. Happy New Year, everyone. So let me make an easy prediction about 2025. It will be a year of conversations about spending, deficit, tax reforms, and debt burden. And the truth of the matter is that the long-term federal debt burden is a healthcare problem. More precisely, it's a problem created by the government's involvement in healthcare. Today, I am delighted to have Michael Cannon to talk about why we should get the government out of healthcare. Michael is a Cato Institute Director of Health Policy Studies. Michael is my friend, but according to the Washington Post, he's also an influential healthcare wonk. And according to the Washington Examiner, he is the most famous libertarian healthcare scholar. So be ready. Welcome, Michael.
Yeah, the other one is really mad.
Yeah, there's only two of you. I mean, my story about getting a job at Cato as a healthcare scholar, and
you ran away screaming.
No, actually, it's kind of much more funny than this. It's like they hired me without ever putting me in front of the at the time director of healthcare policy study. And my first day at Cato, listeners will know this because they've heard me say it, was September 11th, 2001. And shortly thereafter, during that day, I met who was going to be my boss. And after probably a minute of talking together, he said, "You don't know anything about healthcare, do you?" And I was like, I had a chance to either lie or come clean. And I said, "No, I don't know anything about healthcare." And we've been friends ever since. So, but it's not you. It wasn't you at the time. It was Tom Miller. It was super, super fun also. And, but anyway, so my first job at Cato was healthcare, and I stayed in that job for about, 5 minutes, literally 5 minutes, because I didn't understand anything. So this is why I'm so excited to talk to you about this. But before we start, I want to ask you kind of a little bit about your history, because one of the things that you and I have talked about is like the difficulty in actually finding scholars to work on healthcare policy. So how did you get there? Why did you pick healthcare?
So I was a young libertarian who had no interest in working in health policy at all. It probably wouldn't have made my top 5 list of issue areas in which I wanted to work. The reason I got into health policy, though, was because I was in a job that I didn't like, and I begged the policy shop where I was working. The organization where I was working was Citizens for Sound Economy. We now call it Americans for Prosperity. I begged the policy shop, "Please, hire me away. Let me do some sort of policy. I'll do anything you want." They said, "Well, we've got an opening in health policy."
Because there's always an opening in health policy somewhere.
We have to tell you why it's open. It's because no one else wants it. It's because everyone else runs away screaming. I said, "I don't care. I'll take it." And I didn't know anything about health policy, but it took me really about 10 years of doing health policy before I felt like I understood what was going on. And that doesn't mean I understand everything, but just like I understood where all the pieces fit. And I was no longer getting questions that threw me because I didn't know exactly how the
10 years, huh?
This piece fit. Well, I'm not very smart. So if you had stuck with it, Vero, you would have picked it up in maybe just 9 or even 8 years, I'm sure.
Yeah. No, I mean, it was kind of, that's the thing. I think this is one of the problem about tackling healthcare, is the fact that first it's so massive and so big that when you start, you just don't even know where to start. I mean, when you begin and like studying it and having kind of, and then there's like, I guess like probably everything else, there's like there's the healthcare per se, and the care and health outcome side of it, and then there's the government financing. And I guess today we're going to talk about the government financing and the role of government in healthcare, which of course has an impact then on health outcome. But I don't know if we'll have time to cover this. So let me start with a question that I've actually come up. I'm really curious about. Can you tell us first about, I guess, the history of government involvement in healthcare? How did it start? And how did it start? What's the history?
Sure. So I was just thinking about what you said about how complex it is, and I do think about it like it's a watch or some really complex piece of machinery where there's all these moving parts and they all interlock in various different ways. And to get your head around it can be so intimidating because there's so many moving parts. And to really get your head around it, you've got to go in there and take it apart and look at this piece and turn it around. And how does it fit with these other pieces? And then, and then you go look at another piece and do that. And you, with that piece, you keep doing it over and over again and then try to get an idea of how all these pieces fit together. And it can be overwhelming. I mean, it took me 10 years. And so whenever we start talking about, when I start giving you the answer to the question, we're going to be talking about one of those small pieces, but it actually there are a few of them that have really large repercussions. And you really shouldn't be too intimidated by it because it's really, even though health and medicine are complex, the concepts that we use to look at other areas of the economy, they all apply in healthcare and can dramatically clarify and simplify it. But to answer your question, when did the government start to get involved in healthcare? It was in the 1800s that physicians initially started pestering legislators to block their competitors who are homeopaths or faith healers or whatever from practicing medicine because they thought that those folks were quacks. But the problem was back then, not only were a lot of those practitioners quacks, but a lot of the doctors, a lot of the allopaths or osteopaths were quacks also. And in fact, medical historians will say that it wasn't until around 1910 when a randomly selected patient walking into a randomly selected doctor's office with a randomly selected disease had better than a 50-50 chance of benefiting from the encounter.
Wow.
So before then...
from benefiting, from not even yeah.
Right. And in the other 50% or whatever of encounters, you could not benefit, which would be great.
Yeah. Consider the alternative
is that the doctor would kill you. The doctors killed or hastened the death of many historical figures like George Washington and some other president who got shot. I forgot which one. And so that effort at licensing didn't really catch on because there was a lot of sort of libertarian sentiment that people should get to make these decisions themselves, mm-hmm. enter the market without government permission. And also the doctors didn't have a lot of credibility because they hadn't really put a lot of distance between themselves and the other practitioners yet in terms of the quality of the services they were providing. And so it's interesting to me that amid all of that, and before, like you saw, government licensing of clinicians pick up in earnest around the turn of the 20th century. It was in the 1880s that German Chancellor Otto von Bismarck decided to create the first system of government-run or government-subsidized healthcare in Germany. It was during a time, I think it was 1883, during a time when the doctors hadn't hit that 50% mark yet, when they were more likely not to help you or even to hurt you than they were to help you. And that's what the government decided to subsidize. I think that's really interesting.
Actually, this is a kind of a good, this could be a good thing to remind people when it comes to any government intervention anywhere. Let me remind you.
Yeah. It sounds like people talk about Chancellor Bismarck and the Bismarck model as though this is a wonderful thing. They were also subsidizing an awful lot of harmful medical care.
Yeah. Mhm.
So
Maybe it was human testing. That's
it
what
was
it was.
around. No, if they were keeping records, you could have called it testing.
Yeah.
It was more just like throwing spaghetti against the wall. So around turn of the 20th century, 1910, is when by 1910 or 1920, like all of the states in the United States had implemented clinician licensing. This is where you have to get a permission slip from the government to enter the market to provide medical care to people. And one of the reasons it happened, and by the way, I'll just give away the ending. I think this has been an absolute disaster.
Mm-hmm.
I would eliminate licensing yesterday if I could, because it has increased the price of medical care. It has reduced, not improved, but reduced the quality of care, and made healthcare less universal. What markets would do by themselves if you just left them to operate, they would make healthcare more universal all the time by driving down prices so that more people can afford it by improving the quality of care at the same time. I'll talk a little bit about why. But licensing interrupted that process. It interrupted that process by saying that where there was this competitive system of medical education and certification, and the government swept that all away and said, we're going to have a monopoly on certification. And if you don't clear all the or meet all the requirements that we put in place, then you can't practice medicine at all. The requirements they put in place were higher than a lot of the requirements that were out there. And that's how they claimed that they were improving the quality of care.
It's interesting because I thought, my intuition would have been that they started subsidizing healthcare, like basically, I don't know, giving money to, or like subsidizing free clinic or whatever the equivalent back there. And from there, and the need for rationing, then the licensing came. But you're saying it's really the reverse. It started with the licensing.
So
and
they did. The government did fund some, clinics and even hospitals before this time. It wasn't very prevalent. It didn't really pick up until the Hill-Burton Act in the mid 20th century. But what subsidies for hospitals existed at the time did become a huge subsidy to doctors, because they got licensing laws to block competition.
Mm-hmm.
And then they got these government subsidized hospitals as their workshops, where they could go and make tons and tons of money without having to lay out the capital themselves to have these workshops. But when the government swept away, or when the government put in place a single set of requirements that everyone had to meet in order to become a doctor, those were higher than what a lot of the medical schools out there were requiring. That meant that the cost of entering the market, the barriers to entry, became much higher. And so you had fewer doctors entering the market. You had fewer medical schools educating doctors. I think about half of the medical schools in the United States closed. And that meant that the price of healthcare went up.
Yeah.
Because if it's going to cost more money to get a medical education to become a doctor, then the doctors are going to have to charge higher prices to recoup that investment.
And the U.S. restrict the supply of doctor quite dramatically, in addition to simply putting a requirement, right?
There are, in order to get a license to practice medicine, you have to graduate from a medical school that the government accredits. And those medical schools will limit the amount of slots. But it's never been clear to me that there's a cap that the government puts on the number of slots. Sometimes the medical schools will collude to say we won't increase the slots because that way they're more valuable. Mm-hmm. But I've not yet found evidence, maybe one of your listeners will tell us, found evidence that the government has placed a cap. They will sometimes limit the subsidies. Now government subsidizes medical schools and medical education. When people talk about a cap on medical school slots, medical school enrollment, they're usually talking about a cap on government subsidies rather than an actual restriction that says to the medical schools, no, you can't enroll anyone else. But if the licensing boards are controlling which schools get accreditation, then that can limit the number of schools.
Mm-hmm.
And thereby limit the number.
Yeah.
So But right off the bat, we see that these licensing laws are making healthcare less universal because they are increasing prices. And so even if the quality is better, and I'll get back to that in a moment, even if the quality were better, it would only be better for people who can still afford medical care, and far fewer people could afford it. So what we saw the number of physicians across the country dropping, especially in rural areas. The per capita number of physicians dropped pretty substantially. But what about quality? The whole purpose of licensing is to improve quality. Well, let me give you a couple of reasons why we should be suspicious of any regulation that says it's going to do that, because those regulations can have very obvious effects that run counter to their effects that we presume that they'll have. One of the things that happened after states implemented licensing laws and the number of medical school slots shrank is there became a lot fewer slots for immigrants, women, Jews, African Americans, most dramatically for African Americans, because there were 7 medical schools in the United States that admitted Black students. 5 of them closed as a result of licensing. The government shut down 5 of them. So there were only 2 left, Meharry and Howard universities. And across the board, at all medical schools, the number of slots shrank. And while the licensing laws were not explicitly racist, it wasn't that the licensing laws said shut down the Black medical colleges. When the government created these shortage conditions, the people with power looked out for their own. They looked out for themselves. And so historian or sociologist Paul Starr says that leading up to government licensing of doctors, you had minorities, Jews, women, African Americans, immigrants making gains in the medical profession. Their numbers were growing because there's a competitive system of medical education that was more inclusive, that encouraged greater diversity. But as soon as licensing happened and that shortage in medical school slots appeared, it reversed that progress. So it made the medical profession whiter and more male. And that right there is pretty clear evidence that even though the licensing laws are not racist or sexist or anti-Semitic, you can still have a regulation that purports to improve the quality of care, can still have a very powerful negative impact on the quality of care. Because if you're excluding women and Jews and Blacks and immigrants from the medical profession, you can't tell me that that's going to improve quality. That's definitely going to reduce the quality of care.
I assume you've read Lauren Hall's book on the medicalization of birth and death. And she talks, I don't know if you've read it, but I mean, anyone should, it's a really great book. And it basically talks about, I think the act, whatever act you talked about, the burden something, whatever act, that basically it was like that organized kind of like how hospital works and dealt with birth, for instance, started like really medicalizing it and making it like a process, kind of a, like in the factory or whatever. And that had a dramatic effect on all the doulas in the Black communities and basically left the country with lots of places that had no hospitals, but also just no way, just terrible care for women. And then it talks about the medicalization of death also. It's a really interesting book. And I like listening to you talk about the licensing effect. I'm reminded of this book because it's I think it's all tied together. So first we have licensing. So it reduces the supply, increases the quality, it decreases the quality, and increase prices. And then when does the subsidies of care, when does that happen?
So the subsidies really don't come along we've already talked a little bit about subsidies for clinics and hospitals and so forth. But the subsidies really don't pick up in a massive way until the 1960s. And a lot happens between when the early 1900s and the 1960s. Licensing doesn't just increase prices and reduce quality in the ways that I've described. It also reduced quality by blocking you from seeing a doctor in another state over the phone,
Yeah.
before the internet existed, or now that the internet exists, it prohibits people from seeing the highest quality specialists in New York or Boston or whatever if that specialist doesn't have a license in your state. So, and then on top of that, and this is actually really where the action was for the first part of the 20th century, is there were entrepreneurs who wanted to make healthcare safer and more convenient, who wanted to employ all the doctors and have them work as a team to provide medical care to people, and have them work on a salaried basis. And the incumbent doctors in the medical profession didn't like these entrepreneurs. They didn't like the competition, the threats that competition posed to their incomes and their autonomy. And so they used the licensing regulations to drive these group practices out of business. They stripped licenses from those people. There's even one case in Oklahoma where they couldn't strip the license from the Dr. Shahid, who founded the group practice, but they were able to strip the licenses from some of the people who would work for him or get them drafted during World War II. To get those doctors drafted so that they couldn't compete. There are a lot of really shady stuff that was going on to reduce the quality, that ended up reducing the quality of care, because if you're like me, you don't have a decent electronic medical record. Mm-hmm. Most people don't. And the reason we don't is because licensing blocked competition from those sorts of plans. Only one of them really broke through and survives to this day. We call it Kaiser Permanente. And it makes healthcare much more convenient and provides electronic medical records, because that's something markets do as a matter of course. And the reason we don't have that innovation, well, there are a couple other reasons also, but licensing is a big one of them, a big part of it.
And so then there's the tax breaks that we get, the subsidies through the tax break, which is effectively a tax on us. But so that tax subsidies, when does it come up? It's the biggest tax expenditure in the list of all the tax expenditure.
Sure. So I resist calling this a tax subsidy or tax expenditure. We could get into the reasons why that is. But it was in 1913, around the same time that states are licensing clinicians that and screwing up their healthcare markets, that the federal government decides to weigh in and screw up the healthcare markets in all states. And the way it does that is by passing the income tax. In 1913, we got the second federal income tax. I always like mentioning that it's the second one, because to remind people that we let the first one expire, and we can do that with this one too. And if you understood the damage that the income tax did to the health sector alone, you would I think that justifies getting rid of the federal income tax. But what happened was they passed the income tax in 1913, and at the time there really wasn't anything resembling modern health insurance. That didn't come onto the scene until about 1929. But there were employers who, would like hire the doctor to see their workers. And they asked the Treasury Department, hey, is the money that we're spending on that type of thing income for purposes of the income tax? Do our workers have to pay taxes on that? And as the health benefits got more sophisticated, more employers asked the Treasury Department this. The Treasury Department threw up their hands and said, look, this is too complex for us to figure out. We're just going to not tax employee health benefits. It's not subject to the income tax. So, and that was in the 1920s, really before 1929 and modern health insurance happened. So when you think about it, it's not like Congress created a tax break for employer-sponsored health insurance. What happened was Congress created a tax on income that never applied to employer-sponsored health insurance.
Yeah.
It's basically a tax on income other than employer-sponsored health insurance.
Yeah.
And so it's not that the government subsidized employer-sponsored health insurance; it just left it alone.
Yeah.
It's just that's what all of our compensation should look like. Have no federal taxes applied to it. But what did that do to people's decisions? That's where it really messed with the health sector, because what that sort of almost accidental decision by the Treasury bureaucrats did was it created a situation where if your employer pays you $1 in health insurance, you get $1 worth of health insurance. But if your employer takes that dollar and gives it to you as cash, you lose about a third of it to federal taxes. So in effect, the government is penalizing you, not only unless you give a bunch of your money to your employer and let your employer pick your health plan and then enroll in a lousy health plan that disappears when you stop working for that employer. And you could have gotten very sick in the meantime. Mm-hmm. You'd had an uninsured and uninsurable pre-existing condition. This is lousy health insurance. Unless you give your employer a big chunk of your money and let them buy that health plan for you, choose it for you, and enroll in it, then if you decide to take that money, and nowadays it's like $25,000 per family, if you decide to take that $25,000 and buy your own health insurance, you lose $8,000 of it to taxes.
Yeah.
And the rest of the health insurance market is so small that it doesn't work nearly as well because the government has already diverted 90% of the market toward this employer-sponsored insurance. And that implicit penalty, that 33% penalty on every dollar of income you take as cash rather than employee health benefits, applies to every dollar of income. So that not only do people decide to get insurance through their employer, because of that distortion of the after-tax prices, they buy more health insurance through their employer than they would buy on their own. Health insurance becomes lower quality because it doesn't cover long-term stuff, but also more comprehensive in the short term. So people demand more medical care because they have more insurance. It insulates them from the price. And because they don't care about the price, because the insurance company is paying, the prices go higher and higher. And you can see how licensing and the tax code are working in conjunction to drive prices higher. Licensing increases prices by directly increasing the prices of every service that you get from a physician. Insurance, or the tax code, increases prices indirectly by distorting the after-tax price of employer-sponsored health insurance, by encouraging more insurance than you would buy otherwise, which then distorts consumer behavior when they're consuming medical care, makes them price insensitive, which distorts the provider's behavior, encourages them to increase prices and not engage in price competition. And so this is all before World War II has even happened. And we get wage and price controls in World War II that the federal government decrees, like the income tax, will not apply to employee health benefits. So your employer can't increase your wages and can't increase wages to attract scarce workers during World War II, but the employer can offer health benefits, and so they do. Oh, along this time, by the way, the marginal tax rate is rising to pay for World War I, to pay for World War II, which makes the distortive effects of the tax code greater. And now let's just fast forward all the way to 1965.
Can I add?
I'll add. The subsidies
No. Yeah, subsidies are coming. But then the thing also that people don't realize, right, is that when a chunk of your compensation comes from fringe benefits, healthcare being the biggest one, right? What effectively it does is actually slow the growth of your non-fringe benefit compensation. Right. And so when people are complaining about the fact that wages are not going up, in large part is because actually total compensations are growing because of the effect that you've been talking about, the incentive to actually provide more of the compensation in the non-tax form of fringe benefits, in this care and healthcare. And that means that while compensations are actually growing, the wage part is not growing. And so I always remind this to my conservative friends when they want to add benefits, federal benefits like paid leave or childcare subsidies through the fringe benefits. And I'm just like, you can't have it both ways. You can't have more benefit provided through your employer and have growing wages or wages that are growing as fast. I
think that's absolutely right. I think that there's a lot of misinformation, ignorance surrounding what is happening to compensation and incomes because of the income taxes, the distortion of how people receive their compensation. It encourages them to receive compensation in these untaxed ways. Meals, free parking spaces, employee health benefits, life insurance, and so forth. And I think the right way to think about those sorts of tax preferences is not that it's a tax break, and isn't it wonderful that the government is giving you this tax relief, but what's happening is there are some forms of compensation the government does not tax, and some forms that it does. And all of that compensation is going to come from you, the worker, one way or another. And so what the government is really doing is when it's not taxing anything, it's not taxing, it's not doing anything. It's leaving you alone if you take your money in the form of employer-sponsored health insurance. But if you take it in the form of cash, I think the way to interpret and analyze what the income tax does is it penalizes you for taking that compensation in a form that you control and that you can spend in a way that reflects your preferences. And that has become an increasing problem over time. Back in 1962, so we fast forward up to the 1960s. In 1962, wages and salaries accounted for 91% of worker compensation. Employee health insurance was 1%. And then the remaining 8% was taxes and other fringe benefits. From 1962 until 2022, so 60 years later, the share of their compensation that workers got to control themselves as cash fell from 91% to 83%. That's because employee health benefits went from 1% of compensation to 6%. And taxes and other fringe benefits went from 8% to 11%. So all those things are squeezing employees' control over their own earnings. And as you say, distorting our picture of what's happening with wages. Because we're only looking at 83% of them, not the full 100%.
But now we're at what? It's like a third, right? A third of compensation on average?
What is a third?
It's a third of compensation is fringe benefits, right? Roughly, so, with the biggest share being healthcare.
The most recent data that I've seen are from are for economy-wide, so people who do and don't have health insurance, average across all of them, and it does include it's from CBO, and it lumps taxes and fringe benefits together at 11%, and then employee health benefits are another 6% on top of that. So there you're at 17%. And the rest they say is wages and salaries. I'm not sure what the 33% figure that you're mentioning measures.
I can't remember where I'd seen that number, but it is always kind of something when people complain, for instance. The reason why this is so relevant, and I have any clue about this, is because there is this, people are complaining that wages are not keeping pace with productivity. That's like the big issue where it comes. And labor economists have actually shown that if you actually include in compensation all the fringe benefits, and you also change the whatever adjusted for inflation type of measure you use for using the economists' preferred one, actually compensations have really perfectly kept pace with compensation, with productivity. And as you would expect, the problem is, again, that so much of our compensations now come from things that you can't decide how to spend. But so okay, let me ask you this, because I don't want to be using wrong words, but so if you say you don't like the word tax expenditures, tax subsidies, so how should I go about talking about that thing?
I try to call it the tax preference for employer-sponsored health insurance.
It is. Well, it is a tax preference.
Exclusion for employer-sponsored health insurance. Those seem to be neutral and non-absurd. You say, because a subsidy is when you give someone something they didn't already have. And in the case of employer-sponsored health insurance, you're not giving the people who enroll those plans anything they didn't already have. It's their money. You're just leaving them alone. And so both the phrase tax expenditure and tax subsidy seem absurd to me because they basically mean tax spend.
Yeah.
When really the government is neither taxing nor spending the money that we're talking about.
Yeah.
And when people say that it's an expenditure, what they mean is that it is a revenue loss to the federal government, because right now employers and workers spend about $1.2 trillion on employee health insurance every year. If the government taxed that, the government would get $350-400 billion in additional revenues. So the fact that the government is not taxing that, people point to that and say, oh, there's this tax expenditure of $350-400 billion. That's really just a revenue loss, not an expenditure.
Yeah, it's a revenue loss. Yeah.
And what a wonderfully vivid example of Stockholm syndrome. You know, the tendency of people to sympathize with their captors, that everybody in Washington, D.C. talks about the effect of the income tax in terms of or this provision, in terms of the impact that it has on the poor beleaguered government that is not taking another $350-400 billion of our incomes every year.
Yeah.
And instead it's being so generous, it's spending that money on us. It's completely absurd. So these are the reasons I use tax exclusion, tax preference, and refer to the income tax as really a mandate machine. And the biggest mandate in that mandate machine is the implicit mandate to purchase employer-sponsored health insurance.
But so the thing really that it's people. So it's interesting. I mean, and a lot of the ways people are talking about that exclusion or that preference, right, is in terms of the cost to revenue. But really, that to us, you and I, is not really the big deal. That's not what is way worse about that tax preference is actually the distortion that it has, the enormous distortion it has on the price of healthcare, the supply of healthcare, the growth in wages, and how it really distort healthcare markets quite dramatically.
Yes, and labor markets.
And
Don't forget, labor markets as well. And so some of the same distortions affect both markets. The biggest way it affects labor markets is that, as I suggested before, it requires you, or it penalizes you, unless you let your employer control a huge chunk of your compensation and use that money to buy a low quality health plan that'll disappear when you leave that job. And this is not an insignificant amount of money that we're talking about letting your employer control. For the average family with employer-sponsored coverage, we're talking $26,000 per year now.
Wow.
That is a huge chunk of money, and across all workers, economy wide, it comes to, as I said, $1.2 trillion. So think about it. If we could somehow give workers control over that $1.2 trillion of their earnings without having to lose a third of it to the IRS, if we could return that to the people, to the people who earned it, that would be a larger share of the economy than the Reagan tax cuts returned to workers in 1981. The Reagan tax cuts were about 2.9% of GDP, but this money that we're talking about, that $1.2 trillion is about 4% of GDP. So this is a huge distortion, and we haven't even gotten to the health sector yet.
Yeah, and so it's a huge distortion. And you said something that was interesting too in passing, is that captures like 90%. You said it's 90% of the market.
Yeah, 90% of people with private insurance, and it has actually that excludes the elderly, but the implications for the elderly were tremendous.
Yeah.
In fact, the tax, if we didn't have the income tax, if Congress had never created the income tax, we wouldn't have the Medicare program right now.
Yeah. Yeah. Yeah.
And the reason for that is, for 40 years, from the 1920s until 1965, the government was penalizing people if they bought a type of health insurance that stayed with them until they died.
Yeah.
There were those plans available even in 1965, but if you said to your employer, no thanks, I'll take that money as cash and I'll buy my own health insurance. It doesn't disappear when I change jobs. The government made you pay taxes on it, so it penalized you. And so more people enrolled in coverage that disappeared when they retired. And then 40 years later, in 1965, Congress looks around and says, why are there so many retirees without health insurance? And that's how we got the Medicare program.
Yeah. And that's how we got Obamacare, right?
That's another. Yeah. So
that's the thing is like, as you're explaining it to this, like me, all of a sudden I'm starting to understand the healthcare, this portion at the very least of the different healthcare program and how they came about, right? Because so if you have another 10% of those getting private insurance, then they have, like seniors, right? They're facing a very big uphill battle to get, it's a small market, so there's very little probably supply, and whatever it is probably a high price tag. And so they complain, and then government comes and say, oop, don't worry, we're going to fix this. This is what the whole Obamacare was about. And then there's the senior stuff that happened before because there's many more of them. It's interesting.
So there's this whole series of laws, just about everything that Congress has been trying to do in healthcare for the past 100 years is to fix the problem that it created when it created the income tax.
Yeah, I never realized this. It's amazing.
We have the Medicare program because the income tax and the tax exclusion specifically mandated that people enroll in insurance. It disappears when they retire. And then we had all these uninsured retirees. So Congress created Medicare. I mentioned how all along during this period, the income tax and the tax exclusion were increasing healthcare prices. That led to a lot of low-income people not being able to afford medical care. That's why Congress created the Medicaid program. At the same time, it created Medicare in 1965. Throughout this period, of course, the left is agitating for a single-payer system. Those calls were being fueled by all of the dislocation that government created through the income tax. You got incremental expansions of the Medicaid program to try to help the poor who are increasingly suffering under these high prices. In 1996, Congress enacted the Health Insurance Portability and Accountability Act, or HIPAA, to try to fill in some of the gaps between employer-sponsored insurance and the other 10% of the private market. In 1997, it created the CHIP program. In 2010, it created Obamacare to try to help people with pre-existing conditions who were thrown out of their employer-sponsored insurance and really fill all those gaps in the private market. Hasn't worked all that well, I don't think. But then there are also all sorts of things that the tax code has done to the quality of care that Congress has been trying to fix. We talked a little bit about the Kaiser Permanente type plans. Not only did licensing inhibit those, but the tax code did as well. And so in 1973, President Nixon signs the HMO Act into law to try to breathe life into this type of healthcare innovation that the government has been trying to kill, it seemed like, for decades. In 2003, I believe it was, Congress passes, or I'm getting my dates mixed up, or was it 2011? Congress passes the High-Tech Act, which is an effort to try to give people electronic health records, just like they have electronic financial records and electronic everything else records. But the tax code and the Medicare program and licensing and all these other interventions had been suppressing that quality improvement for decades. And here comes Congress trying to subsidize its way out of the problem that it created, and that hasn't worked either. And there are lots of other examples of Congress legislating. Oh, there's No Surprises Act. You may have heard of that one.
No.
I think in 2020, Congress passed that law to try to eliminate surprise medical bills. Surprise medical bills are the problem that they are because Congress has done so much to inhibit those type of Kaiser health plans where you don't get those kind of surprise medical bills. So everything that people complain about in healthcare now, we can trace back either to the income, probably to the income tax, and also to a couple of other things the government did that had been increasing the cost and reducing the quality of care for 100 years.
Yeah. I mean, this is why now it all makes sense to me. I've heard you tell that story about the healthcare system as this children's song with the woman who eats a fly, who eats
the lady who swallowed a fly.
Yeah.
She swallowed the goat to catch the dog, swallowed the dog to catch the cat, swallowed the cat to catch the bird, swallowed the bird to catch the spider that wriggled and jiggled and tingled inside her. She swallowed the spider to catch the fly. I don't know why she swallowed the fly. Perhaps she'll die. We're beyond goat. We're at like
it's amazing. It's like
in terms of government control over the health sector, instead of going back and solving the problems that the government created by addressing the source of the problem, which would require reducing government intervention in healthcare, government says no, we're gonna increase government intervention instead. Because there are people making money off of the old interventions and they don't want to see them go away. And the health sector spends more money lobbying Congress than any other sector of the economy, 6 times what the defense industry spends.
Wow, that's amazing. So big distortions. I mean, like basically are we getting less healthcare than we would have, or less diverse type of healthcare, more of a one size, it's not quite a one size fit all, but it's less quality healthcare compared to what we would have gotten, more expensive healthcare. On the innovation front, less innovation.
So low-income people are getting less medical care than they would if the government had never intervened. Mm-hmm. Everyone else is getting more medical care than they would if the government had never intervened. And everyone is getting worse medical care.
Yeah. And yet America remains a place for innovation in healthcare compared to other countries.
Yeah. So the innovation is, we do better than other countries on innovation when it comes to coming up with the new pill or the new cure, the new treatment, the new tests. Because in the United States, government exerts as much control over the health sector as in other countries, but it makes different decisions with all of that power. It is always hitting the accelerator. It is always saying more. Our Medicare program has no fixed budget. Congress pays for whatever the doctors, hospitals, and health insurance companies order up. Same thing with the Medicaid program, unlimited spending. As I mentioned, the tax code penalizes every dollar you don't spend on healthcare. So all of these things just hit the accelerator, which means that spending is higher, prices are higher, and the rewards to developing that new pill are going to be higher here than any place else.
Even if it only extends your life for like 3 minutes.
Right. Well, we'll get to that in a second. Because we're a large country, we're a wealthy country, and we spend lots and lots of money on healthcare. We have the highest prices in the world, including in government programs. And so when the rewards are that great, drug companies do come up with cures like Sovaldi, which is a cure for hepatitis C.
Yeah.
Which is wonderful.
Yeah.
And then it goes to other countries and saves lives there, and France gets credit for that rather than the United States. Fine. I don't even care. But there are also, as you say, a lot of marginal drugs that it looks like are innovations that we really didn't need. They could be inefficient innovations, and innovations where, because the prices we pay for them are so high, or I should say that the government pays for them are so high, the manufacturers are capturing more value than they're creating, which is not how it's supposed to work. That's one category of innovation, though. That's new stuff or new tests and treatments. And we do pretty well, maybe even a little too well in that area. Where we are sorely lacking is on the cost-reducing innovations, like care coordination, so that you don't have to go to as many doctors because they're all talking to each other, or you've got some team leader who will save you and them time by coordinating care. Innovations like electronic health records that make communicating with your doctor so much lower cost. Innovations like telehealth, which licensing laws basically prohibit on an interstate basis.
Even after COVID? Did they?
So there's still states that prohibit interstate telehealth consultations. And I can tell you stories about, the patient who is in Atlanta, and just to have a Zoom consultation with her doctor in Boston had to drive all the way up to Massachusetts and get a hotel room just to log on to the internet and do a telehealth consultation, because she couldn't do it in any of the states in between.
Wow.
And because every one of those states prohibited it.
Actually,
So,
I have a question. I have a question
yeah.
on this. So I just joined like a few months ago medical one with Amazon. Have you ever tried this? And I've only used
So,
it once. And so the way I want to understand how it works, but my experience has been I needed a consult because I'd been sick, and 10 days later I was still like hacking like crazy, and I wanted to know if maybe I needed antibiotics or something. So I made an appointment. 15 minutes later, they connected me to a doctor. I think she was a PA actually, and I assumed wrongly, apparently, or possibly, that basically they had, oh, isn't it great? Like because of COVID, and they allowed telemedicine, and they lifted some of the restriction on seeing a doctor in another state. I assumed she was possibly somewhere else, but it's actually possible that what they're effectively doing is connecting me to someone who is in Virginia.
sure.
Yeah.
And it is wonderful if you don't even know, and not knowing doesn't matter.
Yeah.
That,
But it would be,
very
but it would be
wonderful.
cheaper. It's already pretty
Sure.
cheap, but it
Right.
would be much cheaper if it could be someone. For all I know, it's like midnight, and it's someone in France, like
Sure.
with an accent. Huh.
Which would be great. They could speak your language.
Yeah. So okay, with the seven.
And one more,
Go ahead.
one more
Yeah.
bit on the cost reducing
Yeah.
innovations.
Mm-hmm.
Some of those cost reducing innovations are practice styles and medical research that tell us, hey, you don't need to do this anymore.
Yeah.
You don't need to, for example, this is a bit controversial, but there's some interesting research on it. You don't need to do an appendectomy for an inflamed appendix, for appendicitis. You can just give someone antibiotics. If we have research that shows that is as effective as an appendectomy, then that is a wonderful innovation. That
Yes.
knowledge says we can avoid an invasive procedure. Antibiotics are much lower
Sure.
cost. It takes you out of commission for less time. The surgeon can go help someone who needs them more, or find a new line of work. And yet we are not getting. And I should mention that those practice styles, the more conservative practice styles, can save a lot of money. The Rand Health Insurance experiment compared people who got free medical care to people who had a high deductible health insurance plan and people who had a Kaiser Permanente type managed care plan. And in the high deductible plan and the Kaiser Permanente type plan, they used a lot less medical care than the people who got free medical care, and they ended up just as healthy. So the managed care can cut back on the wasteful stuff just as well as cost sharing can, without hurting anyone's health. And they also do a lot of medical research, because those types of plans have a defined patient population. They have an incentive not to waste any money on anything that's not going to improve your health. And they have the electronic medical records that help them do that, and do research that tells them what is going to be the lowest cost way of meeting this, of delivering this health outcome. And we are sorely lacking for all of those types of cost-saving innovations, because of all the things that licensing laws and health insurance regulations and the tax code and government entitlements have done to tilt the playing field away from those types of plans toward the plans that don't do nearly as much medical research, or don't coordinate care, and don't offer electronic health records.
Oh man, I'm depressed now.
Oh, I'll depress you more.
Please don't.
You are. There's a chance you might remember the drug Vioxx.
No.
This was a COX-2 inhibitor, a drug that Merck introduced. It was a new blockbuster pain reliever, non-steroidal anti-inflammatory drug that earned Merck a lot of money, and the FDA approved it after a couple of clinical trials with a few thousand people in it. Only there were suspicions once it got out onto the market and millions of people were taking it that it might be causing heart attacks.
Oh, that's a bummer.
If you know anything about the Federal Food and Drug Administration, you know that they require a couple clinical trials with a couple of randomized controlled trials with a couple thousand people in each. And if there are no serious safety issues that show up in those trials, they'll approve it. And then they do basically nothing to monitor the safety of the drug after that, even though we know that some side effects will not appear in those smaller trials. They'll only appear once you start giving the drug to millions of people. Well, once that drug went out onto the market, people began having these suspicions that it was causing heart attacks. The FDA was like, we don't know. We don't have the authority to require these bigger trials. We rely on people to report incidents to us, which is a terrible way of collecting data. Mm-hmm. But Kaiser Permanente, that had millions of enrollees and the electronic health records that they needed to pull all the records, pulled the records of the patients who got Vioxx, compared them to the patients who didn't, and said, hey, we think there's a problem here. We think that this is causing adverse cardiac events. And those are the data that the FDA used to pull Merck from the market. So here we have this innovation, this market innovation that entrepreneurs just came up with by themselves that beat the FDA at its own job.
And FDA, I mean, impose an enormous price tag to bringing drugs to market. So on one hand, it really limits the supply, creates shortages and stuff like this, but all this to not do the work properly.
And I might blow your mind a little more when I point out the date that the FDA first got those powers and why. It was 1938 that Congress passed the Food, Drug, and Cosmetic Act that gave the FDA the power to keep unsafe drugs off the market. They did that in the wake of the elixir sulfanilamide tragedy of 1937 and 38 that killed 105 people, including about 30 kids. The drug was safe. An additive was poison. It was basically antifreeze, a close cousin of antifreeze, diethylene glycol. And it led to a very painful death. You're a mother, Vero. I do not encourage you to read the letters that the mothers wrote to President Roosevelt. And almost no one sued the doctors who prescribed these drugs, which was wild because they were so much for licensing. They were grossly negligent in how they prescribed sulfanilamide for indications for which it is not effective. But 1937 was 20 or more years after states had begun licensing clinicians and clinicians had begun using those powers to block group practices, the kind of group practices who wouldn't want to spend money on this drug for their patients unless they knew it was going to work, because that money would come out of their pockets, and who then represented a big fat target that patients might sue. They're more likely to sue a company than they are to sue their individual doctor who they like. And so what licensing did was it removed from the market people who would have asked the Massengill company a few more questions about this solvent that they're diethylene glycol that they're using to make this sulfanilamide more palatable. It could have avoided that tragedy, but because the government removed from the market people who might have saved some number of those lives, the government then said, well, the market has obviously failed. And so we have to step in and create this agency that is going to block drugs from the market. And as you know, has actually caused more harm to health than it has prevented, because over the decades, it has blocked so many drugs from the market for so long that death toll has outweighed the lives that it has saved by slowing or stopping the approval of harmful drugs.
Well, thank you, Michael, for this bummer. But actually, it's great. I mean, it's like
just when you think you're depressed enough.
No, thanks. This is great. And this is actually setting the stage really well for the conversation that you and I will have next week with Brian Blaze about what do we do in the context of the Department of Government Efficiency or outside to actually just reform healthcare. Now, obviously, we want to reform the government payment side of things, and the regulatory side of things, but it's for the benefit of healthcare. And so this is great. Thank you so much for starting the year with me. Talk about this history that I knew nothing about. I've learned a lot. Thanks.
Thank you so much for having me. Let's do it again.